I'm now realizing that the title I picked makes the surprise up front. So thank you for having me today. I am going to start with a clinical presentation. Our initial proband came to us when he was 6 years old. He actually came to the allergy clinic for food allergies. And during that visit, he was noted to have a poor growth curve over time. He had lymphadenopathy, CBC revealed pancytopenia, and at the time he didn't have any signs of hemolysis. Because of his pancytopenia, he was referred to hematology, and they did a bone marrow biopsy, which was normal cellular trilineage hematopoiesis, no signs of malignancy. Other things to note, then a year later, he returned. At this point, he started having recurrent fevers with lymphadenopathy, hepatosplenomegaly, continued pancytopenia, and notably, he had hypergammaglobulinemia and elevated inflammatory markers. At this time, we looked, and his IgG and IgA were both elevated. His IgM was elevated very significantly, 3 times above the normal reference range. He also had elevated IgE, which is consistent potentially with just atopy. So he was evaluated for autoimmune lymphoproliferative syndrome, ALPS, through Cincinnati Children to look because of signs of immune dysregulation. At that point, he only had 1% double negative T cells, and on ALPS functional testing, he only had 2 of the 4 manifestations of the Cincinnati Children's functional lab testing, which was consistent at that point, less likely to be an ALPS presentation. But in addition to elevated ESR and CRP, he also had elevated soluble IL-2 receptor and IL-10, IL-18, and also vitamin B12. At 9 years old, he had recurrence of this non-hemolytic anemia and had a repeat bone marrow biopsy, which remained normocellular without any other signs of malignancy, though there were non-caseating granulomas seen at that time. His rash and fever increased until it became daily for a period of time, and this was also accompanied by abdominal pain. At this point, his hemoglobin, which had been low, progressively decreased to the point where it was severely low and he required red blood cell transfusions. And at this point, during this period of worsening anemia, he did become symptomatic for hemolysis with a positive DAT. And so this is our patient who first presented to us with these symptoms. And then his previously healthy older brother, as we were doing the workup for our younger brother, he began to have oral ulcers and weight loss. He actually didn't have vasculitis at this point. I was jumping the gun by putting that on the slide here. But he did have lymphadenopathy. And he had 1 episode of a febrile illness with erythematous rash that lasted about a week and was responsive to steroids. Family history was really only notable for a father who had oral and nasal ulcers and a paternal grandmother who, by report, had lupus, but we didn't have all of the details about her diagnosis. So at this stage, during the hospitalization for the younger brother, who was the brother who first presented to us, he underwent whole exome sequencing to try to have a comprehensive look to see if we could find pathogenic variants that may be impacting his course and see if there was something that we could do that would be more disease-specific management. So the whole exome sequencing revealed 2 novel missense mutations in ADA2. The paternal location was 1327. The protein location was 443, and the maternal was genome location 401 and protein location 134. And each of the 2 brothers were found to be compound heterozygotes for both of the parental mutations. In addition, they were also found to be positive for, sorry, before I move on, I just want to point out that these mutations were not previously seen in NOMAD or in any of the DATA2 published literature at the time. And based on functional algorithms, 6 of 6 functional algorithms predicted that they would, both variants would be pathogenic. Sorry about that. And so there was a parentally inherited early termination sequence for FAS. That is the gene that's responsible canonically for autoimmune lymphoproliferative syndrome, ALPS. FAS is an autosomal dominant disorder. This pathogenic variation, or this variant, was not found in NOMAD, but it had been previously published to be pathogenic in a patient with ALPS. And so trying to think about the pedigree for these patients. Each of these patients, the father was heterozygous for one ADA mutation and one FAS mutation. Mom had one ADA mutation, was wild type at both FAS loci, and each of the two boys was compound heterozygotes for ADA2 and had one of the FAS variant. One of the variants was within the receptor binding domain of ADA2, and the other was within the catalytic domain. So we, like many people in this field, we sent these results to the pillar of our field, the laboratory of Michael Hirschfeld, who showed that the mother's ADA2 level was within the carrier range, but actually the father's ADA2 level was within the normal range. But both of the two brothers had ADA2 levels that were enzymatic activity that were clearly in the ADA2 deficient range. And so our understanding of why the mother's was in the carrier range, but the father's was above what was considered the carrier range, is that as it is a missense mutation, there's a wide variation of how heterozygotes with missense mutations can present in terms of their ADA2 activity level. There were questions about whether or not the father was sick or had some other thing that may have been temporarily driving up his ADA2 level at the time that this was submitted. And as far as we know, there was no inflammatory driver to make his level at that point higher. And so at this point, we contacted Pui Li and Liang Chen in his lab, and Dr. Li performed MICTAG ADA2 protein detection from the cell lysate of transfected HEC293 T cells, which showed that both variants had significantly lowered protein expression in that assay, kind of somewhat consistent with the mother's being nearly undetectable in the assay and the father having some residual detectable level in this setting, with the my understanding that this is approximately 20-fold higher than the endogenous gene expression of these two in this protein overexpression system versus in plasma. And so transitioning to talking briefly about ALPS. So ALPS is an immune dysregulation disorder due to defects in FAS or other genes and proteins within the signaling pathway of FAS and FAS ligand, and it causes impaired apoptosis and lymphocyte homeostasis, which will then cause unregulated continued lymphocyte expansion beyond the initial infectious stimulus and inappropriate lack of apoptosis when an infection is over and things should be returning to steady state. And so this patient's and their father's mutation is in the extracellular domain, which was an early termination codon, which was predicted to cause nonsense-mediated decay. These nonsense-mediated decay phenotypes are generally milder because they present as sort of like a haploinsufficient presentation versus within the death domain. You can actually make protein, but then it acts in a dominant negative to interfere with the other non-mutated protein and will actually cause generally a more severe phenotype. There's been evidence that the penetrance in terms of how many patients with pathogenic mutations will present is approximately 100% in terms of like cellular and laboratory phenotypes, but it's only between 25 and 45% clinically. And so trying to determine if this patient also had clinical laboratory symptoms that were consistent with FAS. The father did have slightly elevated serum FAS ligand level above the reference range, and each of the two brothers had significantly elevated serum FAS ligand levels, which actually did decrease after reinitiated treatment. In addition, we sent apoptosis testing to Cincinnati Children for both of the two brothers, both of whom showed mildly impaired apoptosis within these lab parameters, with some patients who have more significant clinical phenotypes having levels closer to 0 to 10%. And so while it is below the standard reference range, it's definitely not as impaired as some patients who present with ALPS. And then just to go back one moment, there have been some reports looking, because of the genetic overlap, at serum FAS ligand levels in patients with ADA2. And in the few reports that I've looked at, it seems that patients with ADA2 deficiency do not typically present with low serum FAS ligand levels. So unfortunately, I couldn't fit all 134 manifestations onto this Venn diagram. And even in being at this conference, I've realized that lymphoma, which I've put here over on the ALP side, has been described in many of the patients who, or in some of the patients who have DADA2. I was generally thinking about DADA2 as being more associated with myeloid malignancies, including AML, but that probably actually belongs in the overlaps section. But as you can see, there is significant overlap in the phenotypic presentation between these two disorders, and so it can be very hard to kind of parse out which mutation is caused by which issue. And so things to note about our patient. So our patient presented initially, his double negative T cells were not elevated, but actually on later examination, they did become elevated. The patient presented with hypergammaglobulinemia and not hypogammaglobulinemia. He had splenomegaly and lymphadenopathy. He initially had what looked like it may have been pancytopenia from potentially bone marrow failure, even though all of his bone marrow samples seem to be read as normocellular and not hypoplastic. And later he did develop autoimmune anemia. He also presented with oral ulcers, his brother presented with oral ulcers as well. And so looking at his hemoglobin level after initiation of treatment. So during his admission for severe anemia, he was initially started on both prednisone and infliximab. And with this combination of treatments, he did have improvement in his fevers with the use of anti-TNF antibodies, but he did not have improvement in his anemia, and he continued to be quite symptomatic. And so in reviewing the literature on treatment for patients with ALPS, we decided to also initiate sirolimus, and he had essentially immediate improvement in his autoimmune hemolytic anemia. He did remain mildly neutropenic and thrombocytopenic while on both of these treatments, and then at some point he was transitioned from infliximab to etanercept. And so the kind of overall reasoning for presenting this disorder is just the idea that there is a very high frequency of patients who express who have multiple genetic disorders. This is from the Journal of Allergy and Clinical Immunology, from a small cohort of 278 families, in which approximately 5% of the families had 2 genes that were presenting as a mixed phenotype. There are other cohorts that have shown somewhat similar numbers, with the idea that this is not a fully rare phenomena, that 1 in 20 of our patients may have a second genetic reason for their current presentation. And so this case also highlights something that many of the people speaking today and yesterday have talked about, which is the phenotypic variability even within families who have, at least in terms of their ADA2, identical genetics. And so I think that this is meaningful to try to have as many of the underlying genetic causes identified as possible, because it will have impacts for both treatment and also medical surveillance while these patients are, within our care. And so one thing that I've taken from this conference is the consideration of whether this patient might benefit from being on a JAK inhibitor, potentially instead of sirolimus, and seeing if that may have some dual benefit for both of these disorders. And so to paraphrase from earlier in this conference, don't shut the door to other diagnoses, even if you're finding patients who have clear either known pathogenic mutations or very low ADA2 enzymatic activity. There may be other contributions to their current presentation that may be hiding deeper within their genetics that would be helpful to have other treatment approaches. And so in that, I want to thank my immunology, rheumatology, and hematology colleagues at UCLA, all of whom cared for these patients as a group. And I also want to thank Dr. Chambers and everyone who contributed to this work. So thank you.
Okay, well, thank you very much, Dr. Cohn. Are there comments or questions from the group? It looks like Dr. Hirschfeld has something to add.
Yeah. So the converse question would be whether ADA2 levels are elevated in patients with ALPS, or whether double negative T cells produce ADA2.
So thinking yesterday about the cohort of GATA2 and how that can seem to impact and drive down ADA2 levels, I think it is possible that I would imagine that in ALPS you would potentially see it like a potential overexpression of what could be kind of the baseline steady state ADA2 level because of the inflammatory milieu. But I would be interested in your thoughts on that as well.
Well, the father's wild type allele might be overexpressing to account for the normal levels.
I can offer you an N of 2 for this scenario. So it is elevated. These patients also have very heavy levels of interferon gamma. When they're actively flaring with ALPS, I cannot state when they're not active.
All right, well, I think we're going to have to move on.